like to introduce Professor Danny Chu from the VA Medical Center in Pittsburgh and the University of Pittsburgh Medical Center. He has done over 60 cases now of the AVNeo. So he's one of the leading experts in the world for doing the AVNeo procedure. So we've invited him to share some of his experiences and some of his criteria that he uses for selecting which patients are the ideal candidates for the AVNeo procedure. So with that, I would like to ask Dr. Chu to please begin his presentation.
Great. Thank you very much for the kind introduction, Damon. Okay. So these are my disclosures. Obviously, the international proctor for JMED for this procedure, and I do receive honorarium for my proctorship and faculty and consultation for JMED. So briefly, I'm going to try to go through my talk in a relatively expeditious fashion because I do think that in webinar, it's more educational for me to answer as many questions as possible. So I would encourage the audience to write down the questions via chat or on paper, and then I'll try to answer them as much as I can towards the end. But briefly, this is the outline of my talk. So as you know, the Ozaki procedure, or AVNeo, it's a very attractive option for aortic valve disease. Professor Ozaki has demonstrated a really excellent, now it's a long-term outcome in Japan. And we recently have described our experience in a national meeting for our procedures performed at both UPMC as well as VA Pittsburgh healthcare system. Briefly, the procedure includes harvesting autologous pericardium, fixating it in 0.6% glyceride solution, and excising the native aortic valve and reconstructing all three leaflets by sewing onto the native annulus. So it's essentially a stemless valve reconstruction technique. Professor Ozaki has demonstrated significant excellent outcome for this publication, which is recently presented at WATS out to 10 years. And we locally at Pittsburgh, this was presented a couple years ago, but now I have over 60 patients or so with excellent outcome, albeit the cardiac point bypass and cross-cut times are a bit longer, but not prohibitively longer. And I want to draw your attention to the pacemaker requirement. In over 60 patients, we have 0 pacemaker requirement for this procedure because we are not sewing onto the AV node at all, and you're not, because we're sewing up to the annulus, we're not affecting the AV node. Conversion to the prosthetic aortic valve replacement is 0 in my series. They have been 100% success. So let me focus on this talk on the pathway to success. I think I believe it's extremely important to involve all the stakeholders, not just the patients, but especially so with the referring physicians, such as cardiologists, even primary care doctors. And especially when you're doing your discussion with the patients, invariably when I discuss patients, I also give them the option of TAVR, standard valve replacement. But as soon as I bring the fact that this procedure requires and uses the patient's own tissue, more often than not, the patients are ecstatic. They don't want foreign bodies in them. I disclose the fact that there's excellent long-term outcome, which I will get to towards the end of my talk. And you get to use your own tissues, and the patients and their family really love it. And it's important to engage the referring doctor, especially the cardiologists and primary care physicians, with some intraoperative follow so that they can. So, if I can request everyone to put mute on their buttons, Thank you very much. It's important that to take some intraoperative photo after you finish and to take loops of your echo pictures or even a movie after you finish and share that with your referring doctors. Because after this procedure, the valve, especially on the echocardiography, looks essentially like a normal valve. It's very, very impressive in terms of hemodynamics. So the referring doctors will look at that and really engage themselves and really feel like they're part of the team. So this is the first step on pathway to success. Obviously, the training, it's JODD has really a outstanding curriculum for this type of procedure, but it is not difficult. Having gone through it myself, I will tell you that for the first 10 cases, it's your learning curve. But this procedure is very different than mitral repair, which I do personally as well. No matter how experienced you are in doing mitral repair, there's always a question whether it's gonna work. Professor Ozaki and Joe MDD together have really made this procedure standardized. Of over 60 cases, I've had zero issues of any doubts of this procedure working. As long as you pick your patients right in the early stages and take your time, attention to detail, and make sure that your commissures are coming up nicely, this is going to hold and it's going to work with minimal, if any, aortic insufficiency. So I would recommend starting in your early stages, first 10 cases, younger patient, normally you have tricuspid aortic valve, because if it's bicuspid, truly zero Sievert's type 1 bicuspid, it's a bit challenging, but it's not difficult. But I would not do those cases as your initial 10 cases. Generous sinus size so you can really see and what you're doing, and limit those early stages to isolated aortic valve replacement. And as you move on to 10 to 30 cases, you could increase the risk profile and add some concomitant procedures. Right now, I do many other concomitant procedures along with AVNeo procedure, such as CABG, maze, other valve replacements, etc. Let me finish, and let me give you a perfect example of a patient that I did a few years ago. It's a relatively young patient, but like many of our patients, are morbidly obese, body mass index of 43. He's short and wide. The challenge of that is his aortic annulus is extremely small. It's about 20 millimeters, with clearly symptomatic severe aortic stenosis. So a couple options I present for the patient. If I do a standard aortic valve replacement without root enlargement, he's likely, because his body mass index ends up with a patient prosthesis mismatch. I offer him a TAVR, but being so young, we don't really have long-term data for TAVR. So invariably, this patient will either need an aortic replacement or a standard valve replacement with root enlargement. However, in my opinion, this patient was a perfect candidate for valve reconstruction with autologous pericardium. And I discussed all the options, risks and benefits, but as soon as I say I get to use your own tissue, there will be no foreign body in you, the patient jumped at opportunity to have this procedure done. We did a very standard protocol. We came out with myoanotropic support with a mean grading of 10. Remember, the aortic annulus was 20, the mean grading of 10. And the echocardiogram, I follow these patients annually, regardless of symptoms. The mean grading was 3.6 at 3 years out. Excellent valve function, no aortic insufficiency, zero calcifications. So this is what I consider a perfect candidate for this operation. Obviously, the criticism of this procedure in my personal series of about 60 is a relatively small sample size. But having done, I would say I personally probably have one of the higher adult cardiac volume in the United States. After your first 10 cases, you're going to be very confident that this procedure is going to work. You're going to take your time. You're not going to worry about it, and you're going to make sure that things are coming up on the commissures. The commissure alignment on the 3 commissures are the most critical aspect from a technical standpoint. The advantages are obviously autologous pericardium, excellent option for infective endocarditis. We've done a few of those in my personal series. They're excellent. Those are young patients who are usually non-compliant and they have bacteria. So autologous tissues are more resistant to bacterial infection in the setting of endocarditis. An excellent 10-year outcome as demonstrated by Professor Ozaki. And in about 5 years, Professor Ozaki now currently have a 12-year data. In 5 years, he will have a 15-year data, and I suspect that is going to be a game changer. Some of the contraindications, obviously, because we don't support the aortic annulus with this procedure, a dilated annulus, anything greater than 29 millimeters, I'll be hesitant of doing this procedure without supporting the root. A dilated aortic sinus, anything greater than 50 millimeters, I would be cautious about doing this procedure because since it's a stentless procedure, you're going to have progressive dilation and you're going to have decreased long-term success. Lack of autologous pericardium or abnormally thick pericardium. There are other anecdotal case reports of using other than autologous pericardium, but long-term data just is not there yet. I'm going to close this talk by giving you the latest data on trifecta valve, which is St. Jude or currently an Abbott, subsidiary of Abbott. Trifecta valve is used by many large centers, including UPMC. It's a primary tissue valve as well as Cleveland Clinic, Ohio. So it's a valve that has excellent hemodynamics, and many people use it across the United States. But this is the latest data. If you look at the trifecta data, the long-term freedom from surgical explant at 10 years out is 87%. So the freedom from reoperation is greater than 10% versus the left-hand panel. This is Professor Ozaki's paper that's published in a peer-reviewed JTCVS. At 9 to 10 years is less than 5%. So this is very telling about the long-term durability of AVNeo procedure. If you look at delay survival, similarly, Professor Ozaki on the left panel has better survival than the multi-center trifecta data on the right. So to conclude, this procedure is safe and feasible as an alternative for prosthetic valve replacement for both tricuspid and as you get more experience moving on to bicuspid aortic valve morphology. Keep in mind that even for a truly Sievers type 0 bicuspid aortic valve with 2 commissures, it is recommended and you must convert that to a tri-leaflet aortic valve neocuspidization. These are some of the references. I'm happy to share that for the data I presented. And currently we have 2 centers of excellence established in Pittsburgh, one at the VA, one at UPMC Heart and Vascular Institute. And we're happy to, and this is my contact information, feel free to email me if any questions arise on future questions as you progress in this journey, and I'm happy to answer that. And certainly, JOMDD will be happy to coordinate and to have surgeons across the world come and train with us. We're happy to provide any help, either by email or physically present at Pittsburgh. That being said, thank you very much for your attention. Happy to take any questions.
Thank you, Dr. Chu. Yeah, we have a couple of questions that came across on the chat. The first is related to your case study. The question was, do you know the leaflet sizes that you used in this particular patient?
Yeah, I don't remember exactly that particular case, but I will say that based on my personal experience, and my series is 60, I personally perform all of them. I would say on average, because my patients are usually bigger veterans, on average, I use anywhere from 29 to 31 for the JMDD sizer. And I would recommend having all 3 leaflet sizes as close as possible. What that means is if you have 31 for all 3 leaflets versus 29, 31, 29, it will conform and co-op much better when they're all the same sizes. So that's what I learned from my experience.
Yeah, I think that's the current recommendation from Professor Crane as well, is that one size different between the cusps is probably the best and the recommended sizing for doing these AVNeo procedures.
Yes, absolutely agree.
There was another question. It was in regards to one of your contraindications. You talked about no autologous pericardium, but Dr. Karate has asked, what about using heterologous pericardium?
So I personally have not done before, but in personal communication with Professor Zaki, he's done a few using bovine pericardium. It's much thicker than autologous pericardium fixed with glutathione. It's certainly feasible. I'll be cautious because there's no long-term data on that. So one would argue, well, why not just replace with a standard stented valve, which is made of bovine or porcine pericardium? So the long-term data is the kicker, but technically it is certainly feasible to use a xenograft pericardium. Yeah.
Okay. And then we have another question, which is, would you consider doing the Ozaki or the AVNeo procedure with an annulus reduction in those bicuspid valves where the annulus is larger than 29 millimeters?
Yeah, I would be cautious in doing that because it depends on what type of annulus reduction you're doing. If you're simply putting pleated sutures on the base of the aortic valve, that has been shown to not be as good as a stented valve replacement where the stent is rigid or a standard aortic root replacement. So the long-term data, I'm a very data-driven person, so the long-term data is what is concerning to me. If the annulus is dilated somewhere greater than 29 or so, my personal bias is that the patient would be better served with a standard stented valve or a full aortic root replacement, because my concern is doing a redo. If the procedure is not going to last, we're not really doing the patient any good.
Yeah, that's a good point. There's another question. Do you do pre-op CT scans on all your patients?
Yeah, I do. That's I absolutely do, and non-contrast will suffice. The preoperative CT scan will give me 2 very important data. One is how calcified their sinuses are, because this procedure requires sewing up the reconstructed leaflet onto the aortic sinus along the native annulus. So if the sinuses are extremely calcified, you have to debride the sinuses a little bit in order to put your stitches in, number one. And number 2, it'll give me an estimate of what size of the leaflet I'm going to use by looking at how big the top of the commissures are. And also it will give me an idea of whether or not this patient is a candidate for this type of procedure.
Okay, great, thank you. Next question from Dr. Dandekar, which is, how long post-op do you continue to use aspirin? Or what, maybe a better question, what is your post-op medication regimen for these patients that are getting the AVNeo procedure?
So for isolated AVNeo procedure, no no coronary operation, no other valve, no maze, etc. I put him on baby aspirin for life. Now, that's what I do. But if you look at Professor Ozaki's series, 3 months is all he keeps the patient 3 months, and that's it, and discontinue it. So for patients who, for instance, have risk of bleeding complications, I put them on for 3 months and I stop it. But most of my patients are veterans. They have significant cardiovascular comorbidity. Even if they don't have coronary disease, they have high cholesterol, hypertension, they sort of have risk factors for coronary disease. So I keep those patients, even if I did not do a coronary operation on them, I keep them on baby aspirin for life.
Okay.
But a minimum is 3 months.
Okay. Another question from Dr. Hamza. He said, would you recommend this procedure to every patient needing AVR regardless of their age?
Yes, I do. The reason is because the only downside I see in this procedure, I'll be honest and I'll be transparent with you all, is that the cross-clamp time is longer than the standard valve replacement, but not prohibitively longer. If you look at the STS database in the United States, an isolated aortic valve replacement, it carries a cross-clamp time of median cross-clamp time of 65 to 70 minutes. Isolated aortic valve replacement in the United States. Now, this is across the whole country. There are obviously surgeons on this call who could do it in 30 minutes. Great, but this is a median. So this procedure, if you look at the expert hand, Professor Ozaki has the highest volume in the country. His isolated AVNeo procedure carries a clamp time of 90 minutes. So really not that much longer. So the bottom line is, even if the patient's older, the hemodynamics of this operation is so good that the heart is really, really happy when you come off bypass. It's a really, really happy valve. So that is the key point, and it's been shown by Professor Zarki's publication. It's been shown by our series, as well as Professor Kronik's series in Germany.
Yeah. Okay, great. Thank you for that. The next question is, do you do any of these cases minimally invasive?
So I personally don't. There has been a case report of an institution coming out of Vietnam, whereas they harvest the target's pericardium with thoracoscopic minimally invasive technique. And right now the challenge is reconstructing these valves really takes attention to detail. So I personally don't do it, and I think doing it minimally invasive would be difficult for this. And I think I'm not sure if there's a way to do this in a minimally invasive fashion. Maybe as the techniques improve, the sizers get lower profile, we could certainly approach it that way. But harvesting the pericardium and cleaning that up, it's a bigger challenge.
Yeah. Okay, thank you. The next question is kind of related to you're talking about the CT scan. The question is, how do you decide the co-optation height of the neo valve before reconstruction? So
the co-optation height really depends on the native commissure. So when you size, one of the more critical aspect of this procedure is sizing. When you size the leaflets, you have to size it to the top of the native commissure. And invariably, the co-optation height, once you size it to the top of the commissure, the native commissure, the co-optation zone is going to be greater than 10 millimeters. And that's by design from this procedure developed by Professor Ozaki. By design, he designed along with your MDD, the size is so that the co-optation zone is greater than 10 millimeters.
Right.
This allows the sinus as patient age to get a little bigger and dilated and still have excellent co-optation. So you'll see, I don't have a video on here on this presentation, but after you do this procedure, the co-optation zone is much bigger than the native. It's greater than 10 millimeters, which is by design.
Yeah. Is it essential to assess the leaflets pre-op?
In my opinion, no, because what's critical is, well, I take that back. I said when you start the program, it's important but not critical, because in one of my slides I said in your first 10 cases I would stay away from bicuspid valves, because when you have a bicuspid valve, you don't know whether it's really Sievert's type 1, which will have 3 commissures, or Sievert's type 0, with really 2 commissures. If you have 2 commissure bicuspid valves, Sievert's type 0, that's going to be challenging because you have to create 1, maybe 2 new commissures. So in your first 10 cases, I would do everything you can to evaluate the valve and stay away from the bicuspid valves. But after you get more experience, it really doesn't matter what the valve morphology looks like.
Okay, thank you. I have a question regarding endocarditis. So Dr. Zhang has said that he sees that endocarditis is one of the concerns in the follow-up. And he's talked with Dr. Ozaki, and Dr. Ozaki has agreed with him on this idea. What's your opinion about endocarditis post-op when doing the AVNeo procedure?
So I believe endocarditis, the patient profiles are usually younger patients who are non-compliant. Either they have psychosocial history or either they're homeless. They usually are IV drug abusers that predispose them to infective endocarditis. So in my opinion, those are perfect patients, because if they're not compliant, the standard recommendation will be a mechanical valve for younger patient. But A, they're not compliant, they don't follow up with their INR levels. 2, they don't come for their echo checks. This procedure is actually better because it's been shown by Professor Ozaki to have good long-term outcome, A, and B, it doesn't require any anticoagulation short for 3 months of aspirin. And aspirin, at least in the United States, is over the counter. And it's resistant to recurrent infection. Data coming, extrapolating data from the homograft used for endocarditis. So I believe that this is a good operation and perfect indication for endocarditis.
Okay, there's a couple other comments on endocarditis. One is asking about do you have any theories about the reasons for endocarditis with heterologous pericardium? And then the second one is, do you recommend anti-aggression therapy? And is it necessary being the autologous pericardium is used? And what about, is there any way of doing something to prevent endocarditis?
So I think that comment probably comes from the Professor Ozaki's series. If you look at all of Professor Ozaki's reoperation series, they're all from endocarditis. They're not for leaflet degeneration. So I will say that endocarditis it's akin to surgical site infection. No matter what you do in the operating room, how clean you keep it, how sterile you keep it, there are going to be times that your wound's going to get infected in any operation. And endocarditis is one of those things that no matter what procedure you do for aortic valve disease, you're going to get it. Okay, even if you use autologous, heterologous, xenograft, bovine pericardium or mechanical valve, you're going to get endocarditis. But I will submit to you that an endocarditis after AVNeo procedure, it's much easier reoperation than a stented valve because you don't have all the foreign body and struts. It's essentially like operating on a native valve. And this is direct communication with Professor Zaki, where most of his reoperations are from AVNeo endocarditis. So in that sense, it really doesn't matter whether you use autologous or a xenograft. You are going to get endocarditis after this AVNeo procedure, just like any other operation. Now, I will tell you that if you look at the data on endocarditis, the etiology is turbulence. Turbulence induces endocarditis. That's the reason why bicuspid valves more commonly get endocarditis. And that's why stented valves get endocarditis, because they're more turbulent. But if you look at AVNeo procedure, the mean gradients are all single digits. They're very laminar flow and very not, by definition, not turbulent at all. So that's the key advantage, in my opinion, that there's a theoretic lower risk of endocarditis after AVNeo procedure than any other procedure.
That's great. That's a very, very, very good to know. That's a very important distinction between using a bioprosthetic valve or mechanical valve and the AVNeo for sure. Next question from Dr. Karate is, did you ever face a reduced movement of one of the leaflets? And if yes, how did you treat the issue? And what about a routine 3-month use of anticoagulation followed by anticoagulation? So what about using an anticoagulant after the AVNeo procedure? And first question was, did you, have you ever seen a valve where you had only one of the leaflets reduce the movement after surgery?
So in early series, I have one case. I think this question stems from the fact that they're probably alluding to the possibility of microthrombi forming on the leaflets. This has been shown with TAVR valves, very clearly shown on MRI pictures. But in this procedure, AVNeo, I have not seen that, albeit maybe I'm not detecting it. I don't get MRIs on all my patients, but I have seen a reduced leaflet. But in looking back in that particular patient, he's still doing fine. It's because the leaflet was thicker, and in retrospect, I probably shouldn't have used it. That's why in one of my contraindications, I say, if you have abnormally thick pericardium, I would be cautious about using that, because you run the risk of having a reduced long-term outcome.
Okay. How about
but I have not used vitamin K antagonists, anything other than a baby aspirin for an isolated AVNeo procedure.
Okay. Thank you. So we got a few more questions here. Do you have some experience of replacing just one leaflet in a patient with only one leaflet prolapse?
That's a great question. I often thought about that. This is the ideal case for endocarditis when you have a vegetation on one leaflet. So I asked Professor Ozaki about that in direct communication. He has personally done it. I personally have not done it because I'm not confident on how a autologous pericardium is going to co-opt against a very thin, normal, native aortic valve. Your stress points are different. So from a biomechanical standpoint, it doesn't make sense to me. I was an engineer, so if you think about the stresses, you have a thicker, even a normal autologous pericardium is thicker than a normal aortic valve. So you have a thick tissue hitting against two other soft tissues. I cannot see the long-term outcome being great if you just replace one with autologous pericardium. So far, my personal bias is I replaced all three of them. It does work, excellent long-term outcome. But Professor Zaki has done just one leaflets. Yeah.
Okay, great. Thank you for that. Question on PhotoFix. Have you ever used the bovine pericardium PhotoFix?
Yeah, I have, but not for this procedure. Again, it's technically feasible, certainly feasible, and I know many institutions have used it, even in pediatrics, where most of the pediatric cases have no pericardium because they're redo cases. But the long-term data is not there yet. Now, I'm waiting for Chris Baer at Boston Children's to give us long-term data as he accumulates more data points.
Yeah, for sure. They've been using PhotoFix quite often in their congenital cases at Boston Children's. So, and Dr. Baird will definitely be talking about that more tomorrow on the congenital pediatric cases that we discussed tomorrow. So one other, let's see, a few more questions here. Which part of the neocusps are more tend to get calcification? The edge, the suture line, or the etacera?
So I would say, if I had to guess, I would say the suture line. But if you look at my personal series, and I have up to probably about 5 years or so with zero calcification. And if you look at Professor Ozaki's series, he has a series that's published in peer-reviewed journal of 110. I'm sorry, I want to say it's 90 or 100 dialysis-dependent patients who we all know are prone to calcification and forming calcium. That series has a 5 to 7 year data with minimal calcifications. And again, people ask why, as scientists, we're all scientists on the call, why are there no calcifications? It's because of laminar flow, because it's minimal turbulence. And that's the reason why bicuspid valves develop calcium faster than tricuspid valves in the native aorta, right? So that's the reason. So if I had to guess, the calcium is going to form on areas that has been operated on, which is the suture area, because of the platelet activation, injury, etc. Because as soon as you put a stitch in, you injure a tissue. So
Right.
that's where I would think fibrosis and calcification may form. That's my theory, but I haven't seen calcification in my personal series, even in Professor Ozaki's series.
Okay. One question on, do you have an opinion of CardioCell as a leaflet substitute?
Yeah, I haven't used it personally, but I know people are less happy with that product compared to PhotoFix. But again, that's just anecdotally from communicating with other surgeons. So I really can't give you a good answer for that. Maybe
Okay.
Professor Baer, Chris Baer may have a better idea on tomorrow's talk.
Yeah. So Dr. Baird has made a comment to everyone that one about the single leaflet replacement in young patients. They've done a series of 40, which he'll discuss tomorrow as well. I'm sure he'll be discussing CardioCell and or PhotoFix for sure. Question: do you tailor the leaflets before opening the aorta just with the echo measurements? So have you ever created those prior to actually doing the sizing?
Yeah, so I actually thought about that, and currently I'm collecting data to see how accurate it is based on intraoperative TEE sizing and based on what the actual size is. It's pretty close and fairly accurate so far, but I will tell you that you'll probably save only about 15 to 20 minutes on clamp time if you do that. So the key to this operation is sizing is number one. So sizing is critical. You want to make sure that 3 leaflets are essentially equal sizes. Number two is your commissures has to come up and meet perfectly, because the co-optation from this valve reconstruction starts from the commissures. When you have a leak after the reconstruction, it usually is around the commissures. Very rarely does the leak come in the middle of the co-optation. So that's my experience, and that's sort of a couple technical key points.
Okay, and then we just have time for one more question, and let's see. So could you explain more about the distinction of indication between AVNeo procedure and valve preservation procedure?
So I believe the question is asking what I would do for dilated aortic root with a normal valve. Would I do a valve sparing aortic root replacement or a full aortic root with AVNeo? Is that the question?
I think the question is, when do you do a repair versus doing the AVNeo procedure?
Oh, I see. For aortic insufficiency.
Correct.
Yeah. So I would always try to repair a valve if in my opinion, is repairable. Native valve is always going to be better than a autologous with an autologous pericardium in the aortic position, because that is not normal. That's not how we're made. Right. So if the leaflets, if the native aortic leaflet is soft and pliable, and in my opinion is repairable, I will always try to repair the aortic valve and leave the native aortic valve leaflets as native as they are, and not use autologous pericardium. So that's my opinion.
Okay, great. Thank you. Dr. Chu, thank you very much for your great presentation. I think the questions from the group were fantastic. We had 94 participants so far, so had a great turnout. So I very much appreciate your time and your expertise on answering these questions, and we look forward to working together with you, especially at the AVNeo Training Center that we've now set up in Pittsburgh with you. So we're looking forward to getting much more expertise from you in the future. So thank you very much for your time today.
Great, thank you.